Can you just comment on electroporation methods?
Please.
As a pick for the future? It looks like a promising thing.
I'm sorry, your question?
Electroporation. Do you think that there will be a future in that?
Irreversible electroporation is the next technology to be tested, and it is a non-thermal ablation. For those who do not know this technology, by a high voltage electric field between a couple or more electrodes inserted around the tumor, irreversible electroporation obtains the opening of micropores on the cell membranes, and it opens calcium channels, and eventually cells, tumoral cells, die due apoptosis. And all cellular debris, at least in theory, all cellular debris are brought away by the bloodstream. So no remnant, in theory, will be left behind. And the second advantage is that irreversible electroporation is saving, at least in theory, is saving neural structures. So it doesn't hurt myelin protection of nerves and also vessels. So potentially this is the new technology to be pursued by ablators.
Since I have heard to speak about electroporation, do you know, because there is a lot of radiology, something about boron neutron therapy or vital color interaction? This is new technology normally used in cancer treatment. Maybe it could be useful for complete ablation treatment. Did you understand the question? Boron neutron therapy? You've never heard about it?
I don't personally have experience in my radiology department.
No. Its boron is used to enter in a tumoral cell, and then about irradiation, destroy only tumoral cell. It's about 20 years. It's used maybe also in Memorial Sloan Kettering. I heard something, they were one of the first to use boron neutron therapy. But of course, okay, it's okay. Thank you.
Thank you. Any more question?
Thank you very much for all speakers and guests.
Maybe.
Only one question.
I have a question for Dr. Mike Tuttle, and if he thinks that there will be some biological profile that will help to select the right micropapillary carcinoma for active surveillance instead of other treatments, because we heard from Stephen Odak yesterday that there is something about it, and if you can give us some tips about it and something new. Thank you.
Yeah, that's a great question, because we with the Fagan Lab, who's my partner, we've tried really hard to identify molecular predictors of who's going to grow, and it turns out we can't identify those. Partly because when we look at the selection criteria for active surveillance, anybody that has extrathyroid extension through the capsule, anybody that has lymph node metastasis, they are already out of the active surveillance program. Those are the ones that are most likely to have the more aggressive features, the BRAF plus TERTs. So when we're selecting a really low-risk group of patients, and it's really hard to subdivide in that low-risk group of patients. So right now, we don't use any molecular markers, although we're still looking for that. The real truth is the natural history of the thyroid cancer. What happens in 6 months? What happens 6 months after that? The ones that had those more aggressive features, they slowly grow over the first year and they go to surgery and they're fine. So right now, there's no molecular profile we're using to pick those, but we carefully watch them the first year or two, thinking that if somebody did have one of those more aggressive molecular profiles, they'd be more likely to change a little bit in that first year or two, and we take them to surgery at that point. But still lots of work going on in that.
May I ask Mike another question? I think Megan Haymart has written on why, I mean, active surveillance, there are many candidates, but not all of those end up being offered active surveillance, in part by hesitancy by physicians. And I'm just asking you to comment, you know, as a surgeon, I've had a fair number of patients, the typical patient that comes in that's young, loaded with nodes, and you're scrolling down a path report that is like pages long, and you finally get, I thought, like, didn't I take the thyroid out? Where's the thyroid? It's way at the bottom of the sheet. And after all of these nodes, you know, 3 centimeter here, this level, that level, then you get to the thyroid and it has a 4 millimeter and an 8 millimeter microcarcinoma. And yet all of these nodes, whatever oncogene is responsible for nodal metastasis was like on in a big way, but they're still sometimes multifocal, but microcarcinomas. It's hard to settle down about microcarcinomas when you've read a fair number of path reports like that. I realize that isn't your patients that's walking in with a small primary. They don't have that nodal disease, but how can a microcarcinoma have this wide landscape, this wide spectrum of behavior?
Yeah. So people always ask that, but if you look at the question backwards, and if you look at every papillary microcarcinoma that you've diagnosed, less than a centimeter, about 10% of them will have lateral neck lymph node metastasis. We don't think about them that way, right? Because if they present with all those lymph nodes, we don't count that as a papillary microcarcinoma. But if you look at every sub-centimeter papillary cancer that's been taken out in your practice in the last 10 years, about 10% have those lymph node metastasis. We tried to study the papillary microcarcinomas confined to the thyroid versus those with lymph node metastasis. The only place we found the multiple mutations like BRAF plus TERT was in the papillary microcarcinomas that presented with big lymph node metastasis on day 1. So I think that's why that we don't see those in the active surveillance program. Those guys are excluded because you can probably count on one hand the number of people that refuse surgery for papillary microcarcinoma and over 5 or 10 years developed all those lymph nodes, right? So I think those papillary microcarcinomas, whatever they have, they diverge early on at 4, 5, 6 millimeters. They have a neck full of lymph nodes. They would never go into an active surveillance management program. But yet we just haven't figured out exactly what. We did sort of a genomic classifier using 40 or 50 genes, and I can predict a little bit, but nothing that we can hang our hat on. But I think clinically, those guys declare themselves differently at that microcarcinoma level, which is what makes it so hard to risk stratify the ones that didn't do that.
Thank you.
The question is for everybody. And sometimes we have a nodule in the thyroid, and everybody assumes it's papillary carcinoma. Under the 10 millimeters is micropapillary. But in this, there is a different kind of biological aspect for the tumors. Sometimes there is a no papillary tumor, could be medullary tumor. And I think after we take some conduct, you need to be sure you are in the area of carcinoma papillary to be quiet. In the other hand, we have patients, right, 3 millimeters, 4 millimeters, especially with microcalcified, and you can see huge metastasis in the lateral and the central area. And the idea is the carcinoma of thyroid, it's a big spectrum. 80 or 90% is the classic follow-up, nothing. But we must be very attentive to don't lose the more difficult patient. Unfortunately, it's very small kind of patient. That's my idea, I think. I don't know what you think about. I prefer have a biopsy. It's not 100 the biopsy, but it's close to that. After, before take a standard conduct. I want to list the opinion.
I think that the most important part of all of this is the ultrasound that you have of your patient, the ultrasound evaluation of the thyroid, and not only of the thyroid, the complete neck evaluation, and it has to be performed for an expert in ultrasound thyroid evaluation, because this is the keystone to take decisions for surgery, for active surveillance, for radiofrequency. This is my opinion.
Yeah, I would agree with you, because I think if we decide we're not going to biopsy these really small thyroid cancers, and I personally give the patients that option, I have to recognize that every once in a while, one of those is going to be a medullary, and I'm not going to know about it, right? If we don't biopsy it, 3 or 4% of those are going to be little small medullary cancers. Or rarely one's going to be a little more aggressive cancer. So if we agree in what the American Thyroid Association says, we don't think the benefit of biopsying everything less than a centimeter outweighs the risk. But one of the risks that we're taking is that we could miss a little small medullary cancer. Now, if we miss it, I don't think that means they're going to die. I don't think it means it's going to get out of control. But you just have to accept the fact that the questioner just said, if you don't biopsy it, you don't 100% know what it is. I'm okay with that, but many patients are not. They want to know what it is, and so that's why a lot of them get biopsied. So it's a risk-benefit, and if we don't biopsy, and we personally don't, we give the folks the options, we do keep in mind that we don't 100% know it's a papillary cancer. You just have to follow that over time.
Hello, I'd just like to agree with the last couple of comments that are made. One of the major threats to healthcare in the US over the next few years that's been described is the rollout of POCUS, which is point-of-care ultrasound, where everyone with a probe in their hand thinks they know what they're doing. But the truth of it is, if that's not rolled out with the right credentials, that's quite a threat, because the patient doesn't get their lateral neck staged appropriately. And so that is a serious concern when POCUS is likely to go out to a wider community without guidelines such as the one that Dr. Randolph has talked about this morning. There is a precarious balance there in terms of staging the neck. And I see many cases where endocrine surgeons say an ultrasound report is an ultrasound report, or do the people who are doing it actually have expertise in that area? So I concur with the comments that have just been made.
Just I wonder, after doing thermal ablation for lymph node metastasis or primary microbilliary carcinoma in the thyroid, is there any other tools apart from the ultrasound to follow if there is a recurrence, or to stratify the patient risk after that or not?
I mean, Mike, you can comment on your biochemical assessment. I think most of us use high-quality cervical ultrasound for the thyroid bed, and the lateral necks is generally considered sufficient. I'm also addicted to CAT scans, so whenever I'm reassessing the neck, I get a CAT scan, fine-cut CAT scan with contrast. The base of skull, retropharyngeal regions, and infraclavicular region are well seen on that, and in my practice I have a lot of advanced cancers, so I like to see those areas too. So ultrasound and CT scan, I think, provide structural assessment. Mike, would you comment on biochemical assessment?
Yes, I agree, Greg. Whether we've ablated or whether we're just watching, in the sub-centimeter ones, it's exclusively ultrasound. I'll occasionally use a CT scan to get a better look at the face of the interface at the trachea or a nerve if I'm really kind of getting out there and watching borderline ones. As I watch these that get closer to 1.5 or 2 centimeters, I do add a CT scan of the neck at baseline to get a better look, to make sure I'm not missing lymph nodes as I'm watching stuff bigger than what you guys are talking about today in the conference. As I get up in that 1.5 and 2 centimeters, I want a little bit more confidence. But then after that, it's if there's nothing there at baseline, then we're following primarily with ultrasound. But as somebody said about the POCUS thing, high quality ultrasound, we don't order just a thyroid ultrasound, we order thyroid ultrasound plus lymph node mapping or with lateral necks, because you only get what they ask you to do. So we refer to it as neck ultrasound rather than thyroid ultrasound.
But without using any biochemical test or thyroglobulin?
You know, in this situation where you, particularly when you have a total thyroidectomy, in the first couple hundred patients, I used thyroglobulin, but the normal thyroglobulin just swamps out any signal from these little things. After a lobectomy, I do use thyroglobulin, but in the active surveillance, I quit measuring thyroglobulin about 5 or 6 years ago.
Thank you.
Maybe the best option for follow-up patients after ablation for microcarcinoma is repeat a biopsy of the central zone or central ablation zone and in the peripheral zone in order to try to find malignant cells. All papers that had long-term follow-up after ablation for microcarcinomas reports only less than 1% of new still have malignant cells in the ablation zone, and they repeat the ablation for that patient, but only 1%.
That's when there is some regrowth of the lesion. But if it's still the same,
yes,
yeah.
Repeat the biopsy in the zone, in the ablation zone.
Thank you.
Yeah, we routinely do that about 6 months or a year down the road, and patients, at least in our experience, patients find it very reassuring. It closes the door, it tells them the scar tissue is not there anymore, and then in those low risks, they may not get another ultrasound for 2 or 3 years. So being able to finalize that our ablation really did work and it worked fine. So I didn't know how patients would accept that, but all of mine were sort of like, yes, let's do that so we know for sure everything is fine. So, you know, it's not mandatory because I think it works 99% of the time. Most of the time when thermal ablation didn't work, it's because they were ablating nodules closer to 2 centimeters, not the little small stuff, right? If you look in the sub-centimeter stuff, almost all of those repeat biopsies were fine.
One thing I wanted to mention, I was discussing with one of my surgical colleagues about this issue, and Roberto, this may be a point of controversy here, but that's what the panel is supposed to be. This idea of posterior hydrodissection so that the thyroid and the lesion is lifted up relative to the nerve, that's very impressive and tolerated well, I understand it, and does ventrally displace the thyroid gland. That doesn't necessarily mean the nerve is left down. Any surgeon knows in goiter surgery that, and actually we found in that study that something like 30% of nerves are stuck to the side of the thyroid gland, not through invasion, but through fascial bands or typically blood vessels that come from lateral to medial. The nerve is coming upward, and so it is banded to the undersurface of the gland. So you may hydrodissect, that may lift up the thyroid and the nodule, but that doesn't necessarily distract it from the nerve. The nerve may still be hugging the lateral surface of the capsule and still be available for injury if you are ablating the posterior capsule. It's something we should all discuss about.
Thank you, Greg, for this observation. Actually, we didn't have any laryngeal nerve, inferior laryngeal nerve injury, but this observation should be taken into account. The reason why the hydrodissection works is not only by lifting up the nodule, but also by cooling the zone. So you have to keep in mind that you have all around the nerve and all around the lesion cool water.
I agree. I'm going to get a whole big bucket of D5W and inject at least 30 cc's. It's very impressive, and I'm going to change my technique based on it. Actually, during surgery, I do the same thing with epinephrine-soaked neurosurgical pledgets. I put them on the nerve, and that cools the nerve as we're dissecting the nerve or cauterizing near the nerve. So I understand that sink of heat in that cool saline is of advantage. I'm just saying that the anatomy of the nerve may not be distanced by that hydrodissection perhaps, but the cooling is undoubtedly a favorable effect.
So thank you. Any more question about?
This looks like a hungry audience. I think a hungry audience.
So we can go to the next section.
Thank you very much. Thank you.